Hello and welcome to our third knowledge drop. Before we get started, this is on Medicaid expansion. Before we get started, I just want to let you all know we will be taking questions today. And the topic is Medicaid expansion. You can just put them in the chat. And this will be recorded as well as being live. And if you have further questions, you can put them in the chat on YouTube, or you can send emails to us at the Great Falls Chamber of Commerce. So welcome, we have some guests here. And so we have guests from Alluvian, Great Falls Hospital, Great Falls Clinic. Never know which way to say it, so maybe you can guide me on that. And then from Benefits, you guys want to introduce yourselves?
Sure, I'm Maya LaSalle. I'm the AVP of Marketing and Community Engagement at Alluvian Health, and we are the Community Health Center here in Great Falls.
Perfect.
I'm Jason Hotchkiss. I am the Chief Financial Officer for Great Falls Hospital and Clinic. That's how I say it. Nobody's corrected me yet. I've been here this is my third week, so pretty new on the ground.
Wow, and they send you to us, huh?
Yes, yes.
Well, welcome.
They must not know me well.
And I'm Casey Husted. I'm the System Senior Vice President at Benefits Health System.
Okay, so talking about a topic today that is on a lot of people's minds. Medicaid expansion, and I know Casey, you have a lot of knowledge, everyone has knowledge here. You're a little new here, but that's okay, you got some knowledge. So do you want to just chat about what the HELP Act was and what's happening with that and what we're talking about? What is the expansion?
Sure. So back in 2015, the Montana legislature voted to pursue Medicaid expansion, which essentially expanded the population in the state that's eligible for Medicaid coverage up to 138% of the federal poverty level. And so just as some context, the federal poverty level for a single person is right around $15,000 a year in income. So 138% of that is right around $20,000 a year. The idea behind the program is that those people are likely in a category that they still cannot afford private health insurance, and so likely would go uninsured if they didn't have an option like Medicaid. And if we can get those people on a program so that they can access preventative health care services, build up their health status so that they can become more of a part of the workforce than they are right now, and ultimately grow to a point that they can contribute to our overall economy and eventually get to a point that they can work themselves off of the program, that is just a beneficial thing for not only the individuals but for the state as a whole. And so that program has been in place since 2016 and has been really effective in the state, and it's a topic of conversation right now because the program is slated to sunset in the middle of this year unless the sunset gets removed at the legislative level during this state legislative session.
So speaking just as someone who's not very knowledgeable in this, hence why it's knowledge drop, the $15,000 a year, that Medicaid program is a federal program, and then the HELP Act's on top of that, or it's all state first? Because I think that's a question people get a little confused about.
So Medicaid is a federal and state partnership type program. Traditional Medicaid is funded 70% at the federal level, 30% at the state level.
Okay.
Medicaid expansion is funded 90% at the federal level, 10% at the state level. One reason that's important is because there is some overlap in the population that's eligible for traditional Medicaid versus Medicaid expansion. So you have people who would be eligible for either. If those people are on expansion, though, 90% of their costs get funded at the federal level, whereas if they reverted to traditional Medicaid, like if Medicaid expansion went away and they reverted to traditional Medicaid, at that point the federal government would only cover 70% of those people's costs. So that immediately creates a 20% cost increase for the state for those people. The estimates that I've seen are that subset alone is worth about $26 million per biennium to the state. So if the program would go away, that $26 million would need to be found somewhere in the state's budget.
Okay.
And just to add a little more clarity to it, when we're talking about the differentiation of the patient population in there, or those that qualify for Medicaid, traditional and other, the traditional Medicaid was really for the elderly, the disabled, pregnant women. It was limited. what expansion did, and that expansion came about by the Affordable Care Act. And originally, it was going to expand everywhere. And then the Supreme Court said, no, states can choose for themselves. And so there's actually 40 states and Washington DC right now that have expanded Medicaid. And really what Medicaid expansion did was put an economic gauge on people to be able to receive Medicaid. It wasn't just a disability or a certain status, it provided an economic indicator. And what I like to look at when we talk about 15,000 or 20,000 for the single person in a year at the 138th percentile, like you said, I break it down into hourly wage. It's $9.81 per hour. So if you make $9.82 per hour, you don't qualify. I don't know anybody making $9.82 an hour or even 81 cents and less that can really afford health insurance. And then when you take into account a family of 4, it ends up being for the household $20.19 an hour that they have to
Total household, not one individual.
total household.
Everyone working.
Correct. So if you're a single parent and you have 3 children, are you making $20.20? If so, you don't qualify. If you're making less than that, you do. So when we think about the economic hardship of our economy today and the inflation that we have, I looked at those numbers, and I have kids of my own that are adult now, who are starting to leave the nest and should have left the nest already, but are in school, so we're supporting still. But when I look at those dollar amounts, and less than $11 per family if you have 2 people working, that just isn't, when you talk about rent you have to pay, food we have to pay today, the 138% of poverty really isn't that high.
And I think to tag on to that, I think aside from the significant economic impact that Medicaid expansion has had on the state of Montana, this has truly impacted real lives to the tune of nearly 80,000 Montanans. So Medicaid expansion helped an additional almost 80,000 Montanans, which is just about 7% of our total state population. So when we really look at Medicaid expansion and the impact it's had, it's real lives. It's a ton of Montanans.
And it's my understanding in Great Falls itself, looking online, getting data, being the new guy, over 20% of our population is on Medicaid.
Just in Great Falls.
Just in Great Falls. And so it is impactful on lives. The one thing I think that gets lost in this, everyone considers the contribution to the state that the state makes to these funds, but often I think forgets how much we in the hospital world contribute to this to offset it. There is a tax in Montana as part of the HUF program, and I had to write it down being the new guy, but it's the hospital facility utilization fee. And that is, right now it's currently set at $70 per inpatient bed day that every hospital pays, and 9.9%, so just less than 1%, that every hospital pays on outpatient revenue. So there's a significant tax to the hospitals that actually helps contribute to this. And I support that. Being in other states as well, the benefits are towards the hospitals, but I think it gets lost sometimes where these benefits go to as well. They go to the dentist, they go to the behavioral health provider, they go to the chiropractors, they go to hospice, they go to home health, they go to the skilled facilities. Because of this expansion, you have people who are able to receive these services, organizations and companies who are able to provide them, and removing it would really eliminate a lot of services for a lot of people. And those dollars to the state, the tax statewide is $93 million. That's how much all the hospitals pay into this program. So when we consider the 10% that the state's responsible for and the 90% that the federal government contributes to it, hospitals are paying $93 million of that.
Wow. So before expansion, before the HELP Act, this population we're talking about that was underserved, what did they do? They just didn't have healthcare?
Yeah, so, a lot of times what happens is those folks go uninsured. I mean, they definitely can't afford private insurance of any sort at the type of income they have, so they go uninsured. They'll wait until their health conditions become way worse and way more acute than they should, and then they'll show up at an emergency department where they, can't be refused care, and so they'll go through the system, they'll be much sicker than, they should have ever gotten because they didn't access the preventative care that would have helped the situation. And the emergency department will take care of them, they'll potentially admit them into the hospital, all sorts of things, and so that's how they'll get their care, but that's also the most expensive possible way to care for those people. And that cost doesn't get, if they come in through the emergency department, yes, they'll get their care, it's going to be a lot more expensive and a lot more difficult than it needed to be, but then in the end, they still can't afford to pay the bills that result from that care. And so hospitals will write that off as charity care or uncompensated care. But in the end, that's money lost to the hospitals, and it has to be, it has to be made up somewhere, whether that's, in historical healthcare, it was always, well, you cost shift to commercial insurers. There's only so much of that can be done. At a certain point, it becomes a matter of if so many patients have no payer source and hospitals are losing significant amounts of money caring for those people without being compensated, at a certain point, hospitals are forced to look at what can we actually even provide, how can we keep our own entity solvent, if we're providing extensive amounts of uncompensated care, so.
And I wanna be transparent with the numbers that I shared and also add to what you're saying. First of all, Medicaid as a fee-for-service provider or insurer does not cover the payments we receive in any hospital I've ever worked in or healthcare organization I've ever worked in, does not actually cover the cost of care that it takes to care for that patient. And so we're already playing behind because the payments we receive do not cover the cost of the care. In Montana though, as part of that HUF program, there is money returned back primarily from the taxes we pay in and then also from the federal government. And candidly, that is a contribution of $417 million back to the hospitals. So we pay 93 and get 417 back as all the hospitals in the state. The issue there is that it still, believe it or not, does not cover the cost to care for those patients. And we have now, with the economy going on everywhere, I've been dealing with it not only here in Montana, but in other states. Like you mentioned, the commercial payers have been the subsidy for the Medicares and the Medicaid patients. But even they're coming to the point where their costs are higher, utilization is higher, and they're pushing back and not wanting to be that subsidizer either. And so there's a lot of tension and pressure from all payers in the healthcare market, not just this situation for Medicaid.
And I would say, on top of that, Benefis cares for an extremely skewed proportion of Medicaid patients. So the Medicaid expansion program is such a key thing for us that if we lost that program and the coverage that those patients we're caring for have, we don't have enough of a commercial payer base that we even could pass that kind of cost on to the commercial payers. It would just be impossible to bridge that gap. It would be truly devastating for the organization, and we would be forced to look at services that we provide right now, that we're providing at a loss, and we're providing them because we're the community health system that's, there as a resource for needed community services, even if they don't make money. We would be forced to look at some of those services and see if we even could continue providing them with the type of financial impact losing this program would have. And I think the reason that is a scary thought is because if you get rid of a service, you're not getting rid of that service just for Medicaid people, you're getting rid of it for everyone in the community, even people with private insurance. And so if you think about some of the, robust continuum of care type things that Benefis offers and that are an economic driver for our community, and you think about the possibility of some of those things going away, it might change, you know, somebody's mentality in a completely different industry who's looking at moving here for, you know, a professional level job, and they're sitting here saying, is this really a community I want to raise a family in or I want to move to if I can't access certain types of healthcare services because they're not available. If they're not available in Great Falls, they're probably not available within a few hours of Great Falls. And so I think that's where it starts to become an economic issue way more than just a healthcare issue.
I 100% agree, and it's not just benefits, it's Great Falls Clinic and the hospital, it's St. Pete's down in Helena, it's every hospital in this state and every community in this state that what she described is going to happen.
And as a community healthcare center, Alluvian, of course, has great partnerships with Benefice and with the clinic hospital as well. Community health centers are designed specifically to serve this population.
Right.
We exist to serve the uninsured or the underinsured. And as a community healthcare center, we really are the healthcare safety net. So we are able to leverage our lower cost model of operating to reduce the pressure and the burdens for our higher cost healthcare systems and hospital systems. So, you know, Medicaid expansion moving forward and existing as is crucial for our community healthcare center, for our hospital systems. That being said, absent Medicaid expansion, our community healthcare center will continue to serve the underserved or uninsured, underinsured. However, it's going to have a significant impact on the services that we are able to provide, the staffing that we have. It will create significant workforce shortages for community healthcare centers, for the hospital systems. So the impact will be great absent Medicaid expansion. You know, we are able to offer our services on a sliding fee, and that's just because of the way we are structured as a community health center. But there still will be major gaps. At Alluvian, almost 75% of our patients fall at the 138% FPL or below. 80% of our patients are at 200% FPL or below. So our ability to serve this population is greatly impacted by Medicaid expansion continuing.
And I'd like to just say that, you know, I've worked in all forms of hospital healthcare, large systems, small systems, independent hospitals, really tiny hospitals, for-profit, not-for-profit. We all experience that same situation. It's across the board. Right now, the organization that I work for is for-profit, and I'm not ashamed of that at all. We pay property taxes a significant amount. We pay income taxes a significant amount. But I want to share something that I think can sometimes get lost in the debate around the for-profit and not-for-profit world. Of the 34,000 patient encounters that we had at Great Falls Hospital last year and hospital and clinic last year, 24% of those were Medicaid patients.
Oh.
And for us to be able to continue to operate in that space and provide that service, we need to be able to afford it, whether we're not-for-profit or not, whether we're community based or not. And so it's key, significantly key for every healthcare provider. And like I mentioned earlier, the dentist, the chiropractor, hospice and home health. We are taking a population who is clinically significantly underserved, financially struggling, and we are saying that because of some of them on their own, I can understand. I think right now, from what I read, of the population who could work that are on Medicaid expansion, there's 4% who are not already working but could work. They don't have a disability or otherwise. And so I take that as not being significantly abused, right? 4%, you might say, could be abusers or so. But when you take that, all of those patients in every healthcare setting and realize the clinical impact and the financial impact to your local pharmacy, to your local dentist, to your local chiropractor, everyone involved in the continuum of care, it's a broader picture than I think folks give it credit for.
When you mention that 4%, I mean, I do think there has been a lot done in Montana, both written into the current law as well as just efforts put in place to monitor fraud and abuse. I mean, I think there has been a lot done to ensure that the people on this program should be on the program. I don't think this is a program that has become something where people are gaming the system and getting on it and they shouldn't be. I mean, there are a lot of checks and balances in place to ensure that doesn't happen, and I think you're right, it's something like 96% of the people in the program are either working, caring full-time for a disabled family member, in school, or have a legitimate reason to be on the program. And I think that is a testament to, you know, how much has gone into wanting this program to be done the right way and serve the people it was intended to serve. So
I know politically there can be sometimes this concept of handout versus hand up. I can tell you from my personal experience, when my wife and I were both in college, we actually had 3 kids at the time.
Wow.
Yep. I'm a late bloomer, I'll be honest. I did some things in my career, chased a few rainbows before I ended up in the accounting world and the healthcare world. But we had 3 kids, and if it was not for the Medicaid program, we could not have been successful in school. And it truly was a help up, or a hand up for us. And I understand that there are a lot of emotions that go along with these types of programs, especially in our environment today, political environment today. And even the federal government is talking about whether they're going to continue this expansion program. It's not just here in the state.
Right.
The impact is, I think, what I would like to share is just so much more significant than people give it credit for. We talk about dollars, the cost itself, but you mentioned, I believe, the economic impact across the board, and then also the personal impact. If it wasn't for the program for my wife and I, we would not be where I am today, quite frankly.
And I think that's true as well. I mean, there's been some studies done on, you know, how long are people staying on this program, and I'm not going to recall the exact number of months of duration that people are staying on the program in Montana, but it's something like a couple of years maybe. And so it is not as if there are 100,000 people that signed up for this program back in 2016 and those same 100,000 people are still sitting on the program. I mean, people are getting on this program, they're getting healthy, they're getting the care they need, they're going out and able to maybe work more, maybe get, you know, a higher level or higher paying job, and get ultimately off the program, which is truly what the program was intended to be, is a workforce development program as much as a healthcare program. And they've seen that be successful. I mean, they've seen people get on it, get healthy, get back off the program. And so I do think that's an important component of it. It's not just the same people sitting on the program for years at a time.
Okay. Well, it looks like we don't have any questions from our audience, which is fine. Like I said, you can submit questions now, later, whatever. I just have one more question, and then if you have any comments to wrap up. So when I think about an expansion of a program that was already in place, there was a reason for that. Not that I expect you guys to know the answer for the reason for the initial expansion, but in my mind, I think about all the changing dynamics, and I never want to just blame things on the COVID pandemic of why, but it did change. It changed our lives, and it changed healthcare, and it changed our economy. But if the expansion was a temporary part, right? It was a temporary bill that's expiring. Do you all know the reason for the initial? Is it because just the need was greater and this was a way to address the need quickly, or?
That was originally, so the original expansion concept was part of the Affordable Care Act, with the primary goal being we had a significant number of people across the entire United States who were uninsured, and we were seeing the significant impacts that had on our health as a nation and all sorts of other things. And so the entire concept of Medicaid expansion, starting at the federal level with the ACA, was to ensure that all Americans had healthcare coverage of some sort, and trying to bridge that gap of these people who would never be able to afford private insurance even on an exchange with subsidies, and who weren't eligible for traditional Medicaid was partly where they were trying to bridge that gap. Because of how it ended up getting rolled out, where it couldn't be rolled out across the whole nation, but instead became up to individual states, you've seen over time various states adopt expansion at different points and in different ways, and have different provisions tied to the program. And so that's why Montana happened to be a state that passed it in 2015. Other states have passed it along the way. I think at this point it's something like, are there right around 40 states that have expansion passed? So I think if 40 or 50 have it passed, that probably shows ultimately it has been proven to be something that works and be the right thing. Some states have been doing this as far back as 2010 when the ACA passed. But I think when Montana passed it, you know, if you're asking about why was the sunset ever put in place, I think it was a new thing for the state, and it was definitely something at the time that there was a lot of controversy and question about, and is this the right thing to do? Is this how we should be, you know, allocating resources and spending money? And so the sunset concept came about as, well, let's give it a try, and then we'll have a sunset built in so that if it doesn't work, it can, you know, phase out. And that was just, at the time, what made some people comfortable with the idea of supporting it, that we weren't just putting something into place that was gonna go on in perpetuity and become, you know, potentially problematic down the road. And then that's just how we ended up here, so.
And we have found that the positive impact from Montana adopting Medicaid expansion far outweighs, I mean, from a human perspective, from an economic stability perspective, from reducing barriers to care and burden of cost on the healthcare system as a whole. All of those benefits far outweigh not having it.
And I think just last week or the week before, the Montana Department of Labor released a study that they had conducted that is showing that exact same thing. I mean, it's looking at the economic impact this program is having across all industries, and showing that it's helping workforce across all industries. It's helping, I mean, it's hugely beneficial to the state as a whole, not just the healthcare providers in the state, so.
So as we wrap up, still no questions, which is fine, that's good. It means you guys are providing all the information anyone needed. Anything else you'd like to add about?
I hope it continues, I really do. And my sentiments here that I express, they seem personal, and there might be folks that read into how they perceive me as a person or politically, because we tend to separate ourselves into political factions these days. But I can tell you that even as the finance guy, I see the benefit for clinical reasons, community reasons, and financial reasons, and truly believe that the financial reasons, the financial benefit to the state significantly outweighs any of the cost that the state is incurring. And you know, my personal view and professional view is that it continues.
Okay. Well, thank you all for having a conversation today. Viewers out there, if you would like, I think I'm supposed to say like and subscribe.
Yeah.
And click the bell icon. I've watched enough YouTube videos, so we'll work on that. And this will be on our YouTube site and our website. And if you have any questions for us, reach out. We got the members of the local community health organizations here. So thank you all again.
Thank
You have a wonderful day. And now we're done. Okay.
We're clear?
So we got to edit that in the studio. So under